Hello and welcome to clinicalpath.com. This lecture is on the pleura. The pleura is part of a specific cell that lines the general body cavity. In embryology, this general body cavity is called the coelom. The coelom is an embryologic term that refers to the whole body cavity as we developed basically from back in the worm days. So this whole central body cavity was the coelom, and in the human it's divided by the diaphragm so that we have a thoracic and an abdominal pelvic coelom. So in clinical medicine grossly we call these the serosa. And the serosas, obviously there are three major serosas. There's the pleura, which we're going to talk about today, there's the pericardium, and then there's the peritoneum. And each of these is important because these are the sites that weep and give rise to effusions. When we talk about the actual histology of them, these are actually all mesothelium. So remember, we talk about epithelium and endothelium. Mesothelium behaves like an epithelium, but actually arrives out of the somite mesodermal epithelium. We treat it as an epithelium because it behaves that way. So when we talk about the pleura of the lung, there are going to be two different pleural surfaces. We have the pleura that actually lines the lung itself, that's our visceral pleura, and then we have the pleura that lines the outer body wall, which is our parietal pleura. And normally there's only a thin smear of fluid between them. Effusions are when we get fluid that develops in that space between the visceral and the parietal pleura. And this is important because we've got to understand the different types of effusions as transidates and exudates. So let's come back here and review our Starling forces, because the Starling forces define changes in the fluid leaving the vascular space. Remember that the major force driving fluid is going to be pressure. Hydrostatic pressure drives the fluid from the vascular space out through our mesothelium or pleura here. And the major force keeping it back in is the oncotic pressure, which is mostly albumin. So when we're talking about the pleura, oncotic really doesn't enter into it. It's all related to hydrostatic pressure. So that the only disease in the pleura that's going to give us a rise in that hydrostatic pressure is going to be congestive heart failure. Remember, the definition of congestive heart failure is an elevated left ventricular end diastolic pressure, and this builds up through the venous tree. So this abnormal pathologic pressure is now driving fluid out, but you notice it's going through an intact set of structures: normal endothelium, normal mesothelium. So this is effectively going to be a ultrafiltrate, and the ultrafiltrate is called a transidate. So think of this as an ultrafiltrate, which is going to have electrolytes and water, but low in protein, low in cells. And that should be compared and contrasted in which we have situations of inflammation or malignancy, because these are actually going to cause physical harm to the endothelial cell and the mesothelial surface. And so now we're going to get leakage through those openings, and so these are going to have high molecular weight proteins like fibrin, and they're going to have abundant cells. And so we're going to call those exudate. It's hard to say anything could be more fundamentally important in clinical medicine than this discussion of effusions. We're talking about transidates, which are ultrafiltrates, therefore in the lung, congestive heart failure, whereas exudates with high molecular weight proteins and cells denote inflammation, pleuritis, or malignancy. So when we talk about what the symptoms are going to be shortness of breath. If there's a lot of pleuritis, of course, we could have chest pain as well. And the reason we get the shortness of breath is when you get enough fluid that you get a compression atelectasis and you decrease the actual lung volume. On physical exam, then, we can imagine what they're going to be. If there's pleuritis, you'll hear a rub, but basically what you're going to see is over this area with the effusion, you're going to hear decreased breath sounds, and you're going to have dullness to percussion. You'll then do your imaging, and imaging is then going to show the accumulation of the fluid, which you're then, of course, going to tap. You're going to do a thoracentesis, because the fundamental question we have to answer is it a transudate, congestive heart failure, or is it an exudate, inflammation or malignancy? So when we take a look at that fluid, this then becomes one of the absolute mandatory tables in medicine. Transudates have very little protein in cells, so they are going to be clear. Exudates with proteins in cells are cloudy or turbid. Proteins are going to be less than 50% plasma in transudates, but more than 50% in our exudates, because the actual physical destruction of the endothelium and mesothelium allow for their escape. When we talk about glucose, glucose is going to be greater than plasma in transudates, but in fact it's going to be less than plasma in exudates because the cells metabolize it. Very few cells are found in transudates, but many cells are found in exudates, and knowing the type of cell tells you the pathology. So viruses and TB tend to have lymphocytes, bacteria tend to have neutrophils. LDH, of course, lactate dehydrogenase, is found in all anaerobic glycolysis because remember, it's the enzyme that takes pyruvate to lactate. So all cells have this. So looking at LDH is just really a measure of whether you have a lot of cells present or not. So in transudates with few cells, it's going to be less than 50% of the plasma, while in exudates, it's going to be more than 50% of the plasma. And then pH is really going to be a measure of lactate. So we're going to find acidosis in exudates. So this is a really important table, and make sure that you're very comfortable when you do a thoracentesis or a pericardiocentesis or you get acidic fluid. This is the universal table that we do for effusions of transudates versus exudates. The second disease of pleura that we have to talk about is pneumothorax. And we divide these, of course, into spontaneous versus tension pneumothorax. Spontaneous pneumothorax just refers to the rupture of what is usually an apical bleb. So you can imagine normal people can form these little cystic air structures at the surface, and if that is going to tear, that's then going to go through the pleura and release air into that minimal space between visceral and parietal pleura. It's mostly seen in young adults, and no surprise, it's increased in smokers. And your patient is going to complain of having a sudden sharp pain. That's the tearing of the bleb and the pleura, which is innervated. And then depending on how much air accumulates, they can develop a mild degree of shortness of breath. It's almost never life-threatening. So on examination, if it's only a small tear with a small amount of air, really, generally speaking, you're not going to find anything. If it's large enough, you might find the findings of pneumothorax. But the diagnosis is really going to be based on the chest x-ray, because on the chest x-ray, what you're going to see is going to be the collapse of the lung. So you'll see the collapse of the lung here, and then the development of the airspace where the pneumothorax has released it. Most of these are benign self-limited, so you can just do watchful watching, but if the patient is symptomatic, you can certainly take a tube and put a thoracentesis tube through and evacuate the air and re-expand the lung. Well, that's a totally different creature than tension pneumothorax. Tension pneumothorax is almost invariably seen in trauma that results in a fracture of the rib. And the fracture of the rib is what tears the pleura. And it tears the pleura in a specific manner. It tears it so that the pleura becomes a flap valve. So if this is going to be our region of tear here, we're going to take a look at it. Here's our region of tear. It tears in a way that creates a flap valve, so that when you breathe in, the air can come in and collapse the lung. But when you expire, the pressure pushes on the flap valve, which then closes off that space. So this is exactly the same mechanism as when you use the foot pump to inflate an air mattress that continually pumps in the air, and it continually increases that pressure, and that pressure then is going to collapse the whole mediastinum and lung towards the other side because of the very high levels of pressure. The natural history then is one of progressive shortness of breath. And because it's a flap valve, it can continue and lead to respiratory failure. So it is a life-threatening disease. On physical exam, when you look at the patient, you might see the shift in the trachea. So that's worth looking for at your first with this trauma patient that's getting short of breath. Obviously, you're going to see hyperresonance in the area over the lung, and of course, there's going to be decreased breath sounds. After that, the key to progressive disease is to recognize you've got failing vital signs because of this compression through it. If you have time, you can certainly do your chest x-ray, and it's not going to look different than any other pneumothorax. You're going to see the collapsing lung and the filling in of the thoracic space with air. In terms of treatment, this is a true medical emergency. So you have to decompress that pressure, and the patient can then survive on the one remaining lung until you can reinflate it. Remember that if we were going to take a rib, let's just draw a rib here, and I was going to cut across it and look at the rib in cross-section, ribs look like this in cross-section. So this is the top, and this is the bottom of the rib. Remember that all of your lymphovascular bundles run on the inferior surface, so when you do your tap, do it on the top of the rib, not the bottom of the rib, because you don't want to traumatize the vessels there. So 2 diseases of pleura. Remember that pleura is a mesothelium. Grossly, we call that a serosa that line the coelomic cavities of thorax and abdominal pelvis. You've got to be able to do all of your effusions, pericardial effusion, pleural effusion, and ascites. Remember, the key is in differentiating transudates and exudates. And then the last important disease of pleura is going to be our pneumothorax. And note the difference between a spontaneous pneumothorax, which tends to be benign and self-limited, versus a tension pneumothorax, which is shift and is life-threatening. That's the end of this discussion. Thank you for listening.